Welcome to our video on renal diagnostic studies. After watching this video on renal diagnostic studies, you should be able to explain the utility of urine analysis, urine protein to creatinine and albumin to creatinine ratios, fractional excretion of sodium and urea, and basic imaging studies including kidney ultrasound, renal, arterial, and venous doppler, bladder scan, and nuclear renal scan in the evaluation of kidney injury. You should also be able to interpret findings on routine urine analysis, urine protein to creatinine and albumin to creatinine ratios, fractional excretion of sodium and urea, basic kidney ultrasound findings, and post-void residual volume. Our basic tools to diagnose kidney injury include urinalysis, kidney ultrasound and bladder scan, nuclear renal scan, urine protein to creatinine and urine albumin to creatinine ratios, fractional excretion of sodium and urea, and kidney biopsy. Routine urine analysis is a simple and inexpensive test that can provide an array of information regarding the kidneys and the collecting system. With this test, the laboratory staff reports the color and clarity or turbidity of the urine, its chemical property and composition based on color changes for various chemicals on a pre-coded stick called chem sticks or urine dipsticks, and a microscopic evaluation for cells, casts, crystals, bacteria, yeast, etc. All the information obtained can provide clues to the underlying etiology of kidney injury or metabolic acidosis, presence of a urinary infection, bleeding of the collecting system, or even problems involving the hepatobiliary system. A visual inspection of the urine color and clarity, or turbidity, can sometimes give us an idea of what's going on with the patient. Urine can come in different colors. Here are some examples for your reference. Orange urine may be seen with the presence of bile pigments or ingestion of carrots, vitamin C, medications such as rifampin and phenazopyridine. Pink urine may be seen with the ingestion of dragon fruit. Yellow urine is normal, although the intensity of yellow varies with how concentrated the urine is. Green urine may be seen with urinary infection with Pseudomonas or ingestion of asparagus, vitamin B, methylene blue, and the antidepressant amitriptyline. Infusion of propofol may also give the urine a dark green color. Dark brown urine is commonly seen with very concentrated urine. It may also be seen in patients with hyperbilirubinemia, hemolysis, or rhabdomyolysis. In the setting of an alkaline urine, purple urine may be seen with the interaction between the Foley tubing and urine drain bag and tryptophan metabolites derived from urinary bacterial metabolism of ingested tryptophan. In addition to reporting color and clarity or turbidity of the urine, a urine analysis can provide the following information. Urine pH, which can be useful in the evaluation of kidney stones or renal tubular acidosis, or the monitoring for effective alkalinizing therapy. Specific gravity. Specific gravity of 1.020 or greater indicates a concentrated urine or presence of high amount of heavy solutes, such as glucose or radiocontrast agent. Low specific gravity may suggest diabetes insipidus or water intoxication. A relative isotonic specific gravity, referred to as isostenuria, may be seen in well-hydrated individuals or in patients who are unable to concentrate their urine despite having a physiological need because of a defective medullary concentration gradient, such as that seen in patients with kidney failure or sickle cell disease. The presence of glucose in the urine may be seen in patients with poorly controlled diabetes, normal pregnancy, or Fanconi syndrome. The presence of ketones suggests the body is getting its energy from fat metabolism, seen in various conditions such as low carbohydrate, high protein diet, diabetic ketoacidosis, starvation, vomiting, or pregnancy. The presence of nitrites suggests the presence of bacteria that convert nitrates to nitrites. Nitrates come from the diet. Diet lacking nitrate cannot have nitrites in the urine, despite having bacteria that can convert nitrate to nitrites. Also, not all bacteria can convert nitrate to nitrites. Leukocyte esterase is an enzyme found in white blood cells. The presence of leukocyte esterase suggests the presence of white blood cells. Bilirubin should not be present in the urine. If present in the urine, it is conjugated bilirubin because unconjugated bilirubin is not water-soluble and cannot be filtered and excreted into the urine. The presence of bilirubin suggests possible obstructive hepatobiliary conditions or liver disease. Urobilinogen is produced from the breakdown of bilirubin by gut bacteria. The majority of this compound is excreted in feces. A small amount is reabsorbed and excreted in the urine. Urobilinogen is present at low level in the urine under normal conditions. Increased levels suggest the presence of hemolysis, liver disease, constipation, or intestinal bacterial overgrowth. Decreased levels suggest obstructive biliary disease or severe cholestasis. Proteinuria, predominantly albuminuria, may be detected. Immunoglobulins from paraproteinemia, such as multiple myeloma, are poorly detected. The urine dipstick also detects peroxidase activity of red blood cells. When this reaction is positive, it is labeled positive for blood. This test can also be positive in the presence of myoglobinuria seen with rhabdomyolysis, semen in the urine, or urine contaminated with oxidizing agents used to cleanse the perineum. With rhabdomyolysis, however, microscopic analysis will be negative for the presence of red blood cells. Following the urine dipstick evaluation, a microscopic evaluation of the urine is performed. The presence of different cell types can be reported. Most common include red blood cells and white blood cells and squamous epithelial cells. When present, bacteria, yeast, naturally occurring or drug crystals, and urinary casts are also reported. Examples of cells and crystals taken from this website. Here we have red blood cells. Dysmorphic red blood cells seen as blebbing of red blood cells. The presence of dysmorphic red blood cells indicate glomerular injury. White blood cells, which are round to oval shape with granulated cytoplasm and segmented nuclei. Aging white blood cells, which are larger and appear swollen. Squamous epithelial cells, which are thin, flat cells. Yeasts and pseudohyphae. Bacteria, rod-shaped or coccoid, seen as single organism, chains, or in groups. Amorphous crystals. This is a common and normal finding seen in more concentrated urine. If these crystals are seen as orange to pinkish crystals at low urine pH, they are likely uric acid crystals. If there are white crystals seen at high urine pH, they are likely calcium phosphate crystals. Close-up view of uric acid crystals. Calcium oxalate crystals which may take various forms including fan shape, pyramid, or envelope form, or oval shape. Triple phosphate crystals, commonly referred to as coffin lid, associated with chronic urinary tract infections. And cystine crystals, seen in patients with cystinosis. Lipids in the urine, or lipiduria, occurs predominantly in the setting of nephrotic syndrome, but may also be present in polycystic kidney disease and Fabry disease. Damage to the glomerular basement membrane allows plasma lipids to enter the urinary space. Excreted lipids may appear as free lipid droplets. These are best visualized under dark field illumination because they are highly refractile. Lipid casts, oval fat bodies, which are sloughed tubular cells engorged with lipids that have coalesced into refractile globules, and or cholesterol crystals seen as geometric plates. Lipids are highly refractile and may resemble Maltese cross under polarized light. This pattern is characteristic of cholesterols and may not be seen with neutral fats such as triglycerides. In such cases, these lipids can be readily identified by staining with Sudan 3 or oil red O. Tubular casts may also be seen on microscopic evaluation of the urine. The glue that forms any kind of cast comes from a protein called 10-Horsfall protein that is made in the thick ascending limb of Henle loop and early distal convoluted tubule. Normally, with good urine flow, this protein gets quickly washed out into the urine. Under conditions when there is renal hypoperfusion with resultant low urinary flow, these proteins build up in tubular lumen and form colorless casts called hyaline casts. The presence of hyaline casts basically indicate a pre-renal state with associated poor urine flow. If there is any kind of injury within the nephron, such as glomerular bleeding with red blood cells, an inflammatory or infectious process with white blood cells, or acute tubular necrosis with dead renal tubular epithelial cells making their way into renal tubules, these cells get trapped by the sticky 10-Horsfall proteins to form cellular casts. If the cells are red blood cells, they are called red blood cell casts. If the cells are white blood cells, the casts are called white blood cell casts. When urine flow is sluggish, cellular casts degenerate within the tubules and become coarse granular by the time they get out into the urine. Coarse granular casts become fine granular casts if they have more time to degenerate within tubules. If these casts get stuck in the tubules for longer time, they become thick and waxy looking and are called waxy casts. Waxy casts generally suggest chronic kidney disease. This is what a hyaline cast looks like. The presence of hyaline casts suggests renal hypoperfusion or a pre-renal state. Red blood cell casts suggest an active glomerulonephritis until proven otherwise. Evaluation for a rapidly progressive glomerular disease must be done promptly. White blood cell casts suggest the presence of an acute tubulointerstitial nephritis or pyelonephritis. Muddy brown casts suggest acute tubular necrosis. Granular casts are nonspecific. They are degenerated cells of unknown origin. They could come from dead renal tubular epithelial cells or degenerated red or white blood cells. Waxy casts suggest chronic kidney disease with low urine flow. Calcium oxalate monohydrate may crystallize as picket fence or fan-shaped. Calcium oxalate dihydrate crystals resemble pyramids. Calcium oxalate crystals may be seen in patients with ethylene glycol toxicity or inflammatory bowel disease. Uric acid may precipitate at low pH as pinkish-orange rhomboidal-shaped crystals. These may be seen in patients with tumor lysis syndrome or individuals with high uric acid intake. Struvite, also known as triple phosphate crystals, may take the form of fern leaf if freshly formed. Otherwise, they are often likened to coffin lids. These crystals precipitate at high urine pH with high ammonia content produced by urea splitting organisms. The presence of struvite crystals suggests urinary tract infections with urea splitting bacteria. Calcium phosphates precipitating as blunt-ended needles or single prisms, rosettes, or amorphous. Calcium phosphates precipitate at urine pH greater than 7. Calcium carbonate crystallizes as small, colorless granules or dumbbell-shaped crystals. The presence of calcium carbonate in the urine is not uncommon and is typically not clinically significant. Cystine crystals are hexagonal crystals that may be seen in patients with cystinosis. These are not seen in normal urine. The presence of amorphous crystals are commonly reported in concentrated urine and are not clinically significant. Amorphous urates may be seen in urine pH less than 7. They often appear in non-crystalline amorphous form with pinkish to yellowish brown color. Amorphous phosphates resemble amorphous urates, except amorphous phosphates precipitate out of solution as white turbid particles at urine pH greater than 7. We can measure urine protein and albumin levels to assess the degree and source of kidney injury. The most accurate measurement of urine protein and albumin is from a 24-hour urine collection. However, this can be cumbersome for patients to collect urine over a 24-hour period. Measuring urine protein and albumin concentrations from a random urine sample is easy to do, but it does not accurately reflect the true degree of proteinuria and albuminuria because urine concentration varies over the course of the day. To correct for the variation in urine concentration, we commonly measure random urine protein and albumin concentrations and normalize these measurements to urine creatinine concentration. Creatinine, a byproduct of muscle metabolism, is normally released into the urine at a constant rate. When both random urine creatinine and urine protein concentrations are measured, the resulting protein to creatinine ratio approaches the accuracy of the 24-hour urine protein test. For this reason, random urine protein to creatinine and urine albumin to creatinine ratios are commonly used to assess the degree of proteinuria and albuminuria in patients with kidney disease. So how do we use urine protein to creatinine and urine albumin to creatinine ratios to help us assess the extent and source of kidney injury? Here we have our glomerular filtering unit. Under normal conditions, low molecular weight proteins are freely filtered, but get reabsorbed almost completely by proximal tubules. Because of this, the total amount of proteinuria, estimated as urine protein to creatinine ratio or UPCR, is typically very low and less than 0.2 gram per gram of creatinine in individuals with normal kidney function. In patients with tubular injury, such as acute tubular necrosis or tubulointerstitial nephritis, the filtered low molecular weight proteins cannot get reabsorbed and get excreted into the urine. Because of this, we can see a UPCR greater than 0.2 in patients with tubular injury. However, because the proteins excreted are of low molecular weight, they do not weigh much. The UPCR is therefore typically less than 1 to 1.5 gram per gram of creatinine. When there is only tubular without glomerular injury, albuminuria, estimated as urine albumin to creatinine ratio or UACR, is very low or within normal range because albuminuria only occurs when there is a defective and leaky glomerular basement membrane seen with glomerular diseases. Low-level proteinuria without much albuminuria in patients with tubular dysfunction is called tubular proteinuria. In patients with glomerular disease where there is injury to the glomerular basement membrane, larger molecules such as albumin can be filtered. When this occurs, the total proteinuria UPCR can be very high, most of which come from albumin. Because of this, urine ACR closely matches urine PCR. When proteinuria is made up predominantly of albumin, it is referred to as glomerular proteinuria. Finally, in monoclonal gammopathy, where large amounts of light chains of immunoglobulins are made, these can be easily filtered. While proximal tubules also try to reabsorb the light chains as much as they can, the excess production of light chains can overwhelm the proximal tubular resorptive capacity. This leads to proteinuria made up predominantly of light chains. This type of proteinuria is called overflow proteinuria, which may be seen in patients with multiple myeloma or macroglobulinemia. In patients with paraproteinemia, where the glomerular basement membrane is still intact, there will be minimal or no albuminuria. Let's try to interpret a few UPCR and UACR combinations. First patient has a UPCR of 1 and ACR of 0.2. PCR is not very high. ACR is also very minimal. Minimal ACR suggests that there is no significant glomerular injury. The total proteinuria, therefore, likely comes from a tubular injury, such as acute tubular necrosis, or tubulointerstitial injury, such as acute or chronic tubulointerstitial nephritis. Paraproteinemia is possible. Clinical correlation is required to see which is the most likely diagnosis. Second patient with a PCR of 5 and ACR of 4.9. These values are very similar. Almost all proteinuria comes from albumin. This pattern is consistent with glomerular injury. Research for an underlying glomerular disease is warranted. Third patient, PCR of 4, ACR of 0.5. There is a high degree of proteinuria that is not made up of albuminuria. Where does this protein come from? Tubular proteinuria is typically less than 1 to 1.5 gram per gram of creatinine. This high degree of proteinuria without albuminuria should raise concerns for paraproteinemia. Fourth patient, PCR of 1 and ACR of 0.9. Although PCR is low, it is made up predominantly of albumin. This pattern is consistent with glomerular disease. Moving on to renal imaging studies. Kidney ultrasound is an inexpensive and non-invasive test that can provide structural information about the kidneys. Kidney ultrasound can evaluate kidney size and cortical thickness. Large kidneys may be seen in patients with severe and diffuse edema called anasarca, hyperfiltration, which is commonly seen in early diabetic kidney disease, infiltrative diseases such as lymphoproliferative and granulomatous diseases, cystic diseases, or kidney mass. Small kidneys with thin cortices suggest chronic and end-stage kidney disease. A kidney ultrasound can reveal obstruction ranging from pelvic fullness and pelviectasis in mild obstruction to cheliectasis and hydronephrosis in severe obstruction. Kidney ultrasound may reveal cystic kidney disease, stones, and large kidney tumors. A renal doppler may be done to measure blood flow and resistance of large blood vessels supplying the kidneys. When there is suspicion for renal vein thrombosis, a renal venous doppler may be done. Or when there is concern for significant renal artery stenosis, a renal arterial doppler may be done. Confirmation with magnetic resonance venogram or angiogram may be done as clinically indicated. Urinary obstruction can start at the bladder outlet and cause urinary retention. When this is suspected, a bladder scan may be performed. In this procedure, the patient is first asked to void. The residual urine volume in the bladder is then measured with the bladder scanner. A residual volume less than 50 ml in an average-sized adult is considered normal. A residual volume greater than 200 ml suggests significant urinary retention that may play a role in kidney injury. Nuclear renal scan, also known as renal scintigraphy, is an imaging method that uses radiotracers to evaluate renal anatomy, physiology, and pathology. Common indications for the renal scan include the evaluation of renal function, obstruction, renal anomalies, mass, cortical scarring, and infarction. Renal scan is contraindicated in pregnancy to prevent radiation exposure to the fetus. This is an example of a normal renal scan with images obtained every 30 seconds after injecting the radiotracer's technetium-99 Mag3. Initially, there is symmetrical uptake of the radiotracer in both kidneys, followed by normal excretion, indicated by the appearance of radioactivity in the ureter, then bladder in later images. This is a renal scan of a patient with obstruction of the left kidney. Both kidneys can be seen here. Over the exam course, there is normal excretion in the right but not left kidney. Normal excretion is seen as the disappearance of the radiotracer in the right kidney over time. The failure to excrete the tracer suggests an obstruction. A diuretic such as furosemide may be given with a renal scan to assess for an obstruction. Furosemide increases urine output, which should speed up the clearance of the radiotracer from the collecting system. However, if there is a structural obstruction, the radiotracer cannot be cleared despite the use of a loop diuretic. Fractional excretion of sodium and fractional excretion of urea may also be used in the evaluation of acute kidney injury. The fractional excretion of sodium, commonly referred to as FeNA, is the percentage of sodium that ends up getting excreted into the urine following glomerular filtration. It is essentially an indirect measurement of tubular sodium reabsorption. The lower the fractional excretion of sodium, the greater the reabsorption of sodium by renal tubules. FeNA can be calculated as serum creatinine concentration times urine sodium concentration divided by urine creatinine concentration times serum sodium concentration. FeNA may be used clinically to answer the question whether an acute kidney injury or AKI is due to renal hypoperfusion versus all other conditions. FeNA is only applicable when patient has non-oliguric AKI, where non-oliguria is defined as having urine output greater than 400 ml per day. A FeNA less than 1% suggests a pre-renal state. A low FeNA indicates that the kidneys are avidly reabsorbing sodium. This is seen when a patient has reduced renal perfusion, as in the case of volume depletion, hypotension, low cardiac output, or severe vasoconstriction. The increased sodium reabsorption helps expand total body volume to increase renal perfusion. A low FeNA also suggests renal tubules are still healthy enough to reabsorb sodium to meet the body's need. Once patients develop acute tubular necrosis, or ATN, after prolonged exposure to renal hypoperfusion, sodium reabsorption can no longer occur despite the body's need, in which case FeNA will be greater than 1%. A FeNA greater than 1% suggests the presence of ATN or any other condition unrelated to renal hypoperfusion. A fractional excretion of urea may also be used for the same purpose as FeNA. The formula is the same as that for FeNA, except instead of using serum and urine concentrations of sodium, we use serum and urine concentrations of urea. In non-oliguric AKI, FeNA less than 1% or Phe-urea less than 35% generally indicates pre-renal AKI as opposed to other causes of AKI. Phe-urea is typically used instead of FeNA in patients receiving diuretics because urea reabsorption occurs primarily in the proximal tubules and is less affected by loop and thiazide diuretics. In contrast, sodium excretion, hence FeNA, can be elevated with diuretic use even in the pre-renal state. When an intrinsic kidney disease such as vasculitis or glomerular disease is suspected, a kidney biopsy may be performed. Serologies associated with glomerular diseases may be obtained prior to the kidney biopsy depending on the clinical history and presentation. Common serologies for glomerular proteinuria as shown may be obtained. If paraproteinemia is a concern, obtain serum and urine protein electrophoresis and serum kappa and lambda light chains. If patient is a female or male but with extrarenal signs and symptoms of vasculitis, obtain ANA and ANCA. When a rapidly progressive glomerulonephritis is suspected, add anti-GBM and ANCA serologies. Summarizing basic tools that may be used to diagnose kidney injury. Urine analysis and urine protein to creatinine and urine albumin to creatinine ratios can offer clues to the source of the kidney injury. That is, does the injury come from glomeruli, tubules, interstitium, or blood vessels? Kidney ultrasound and bladder scan can offer information about renal structure and collecting system. Dopplers can offer information about blood flow in renal arteries and veins. Fractional excretion of sodium and urea can provide information on the necessity for and effectiveness of renal tubules to reabsorb sodium and urea when there is a pre-renal state. A renal nuclear scan can give more information on structure and function of the kidneys. Finally, when there is suspicion for an intrinsic kidney disease, particularly concerns for a glomerular disease, a kidney biopsy may be performed. At this point, you should be able to explain the utility of urine analysis, urine protein to creatinine and albumin to creatinine ratios, fractional excretion of sodium and urea, and basic imaging studies including kidney ultrasound, renal arterial and venous doppler, bladder scan, and nuclear renal scan in the evaluation of kidney injury. You should also be able to interpret findings on routine urine analysis, urine protein to creatinine and albumin to creatinine ratios, fractional excretion of sodium and urea, basic kidney ultrasound findings, and post-void residual volume. The end.